Within healthcare, dermatome and myotome assessment offer the advantages of better diagnosing whether a person's problem has a neurogenic element, while subsequently allowing a more accurate and proficient treatment plan. But what are they and how can they be assessed? Today we explain how. But first, as always, please take note of our disclaimer. To discuss both, we need to begin by becoming better accustomed to our vertebral columns, or as you're probably more familiar with, our spines. The spine is divided into 5 areas from cranial to caudal: the cervical spine, the thoracic spine, the lumbar spine, the sacral spine, and the coccygeal spine. We don't need to get into the coccygeal spine though, because it doesn't very much relate to dermatomes, and not at all to myotomes. Because of the difference in their anatomical arrangement, we'll first discuss the upper 3 sections of the spine, and then the sacral spine. The cervical spine, or roughly the neck, has 7 articulating vertebrae, numbered C1 to C7. The thoracic spine, or roughly the chest and upper back, has 12, numbered T1 to T12, and the lumbar spine, or roughly the lower back, has 5, numbered L1 to L5. Each vertebral level houses a pair of spinal nerve roots, one for the left side of the body and one for the right. Each nerve root has a dorsal aspect containing the sensory nerve fibers that allow you to process things like temperature, pressure, touch, and pain, and a ventral one containing the motor nerve fibers allowing you to move your body, which both form together into a single spinal nerve and go on to exit the spine for most of the C, T, and L spinal nerves through a gap known as the intervertebral foramen. As a result, most are named in accordance with their corresponding vertebrae. So a spinal nerve exiting the C4 vertebra, for instance, is also called C4. Yet in the cervical spine in particular, there are actually 8 spinal nerves, even though there are only 7 vertebrae. This is because the C1 nerve exits above the first cervical vertebra, while the C8 nerve exits below the 7th cervical vertebra, just above the T1 cervical vertebra. Thus, there will be one more cervical spinal nerve than the vertebrae left over. So, how does the sacral spine differ from the cervical, thoracic, and lumbar spines? Well, for adults, the sacral spine is different because it doesn't have vertebrae. They fuse together during adolescence to form a single bone called the sacrum. This occurs during growth to enhance structural stability in the region and support the load placed on the pelvic girdle by better connecting the spine to the pelvis. However, the sacral nerves, i.e. S1 to S5, still have similar neurological anatomy to the other nerves, just they exit into the lower extremity from the vertebral column through little holes known as the sacral foramina, as opposed to the intervertebral foramen. Anyway, now that that's covered, let's talk about dermatomes. In a nutshell, dermatomes are areas of the skin supplied by each spinal nerve's sensory nerves. So each spinal nerve, with the exception of C1, is associated with an area of the skin, helping us put a map together of the bodily sensory distribution. This gives a practitioner a better idea of the origins of pain, pins and needles, or numbness, so they can have more transparency into what's going on and thus help orientate treatment plans better. To show you what I mean, I will use a basic example to keep things simple. When someone feels one of these sensations at the bony protrusion of the elbow, which, as you can see on the map, is the C7 dermatome, this means that there may be a dysfunction causing it at the C7 vertebra. As such, a physiotherapist in particular may then decide to focus treatment partially on improving the mobility of that vertebra to relieve the symptoms rather than working on the elbow directly itself, because the dysfunction could be arising from narrowing at the intervertebral foramen due to stiffness, which is causing the relevant nerve to become impinged and resulting in radiation down the back of the arm. Therefore, you can see how we can establish more accurate treatment plans by applying the knowledge of dermatomes, enhancing our confidence and competence in our practice. So here's a way you can check them. Ask the patient to close their eyes, then gently apply a pin and cotton wool to the area of skin in question. If they can't feel the cotton wool or state that the pin feels blunt, when it should feel sharp, then this indicates that something is wrong with the dermatome. Okay, so that's for dermatomes. Then what about myotomes? But just on a quick side note, If you want to undertake our evidence-based and results-backed personalized plate weight management program, please click the link in the top right-hand corner of the video or follow the link in the description. In contrast to dermatome testing, which allows us to assess how well the sensory fibers of a spinal nerve work, myotome assessment gives us an idea of how well the motor fibers of a spinal nerve work. We check myotomes through isometric strength testing. Weakness is a positive indication. The Oxford scale is primarily used to classify the level of strength present, grading it from 1 at the lowest to 5 at the highest. However, checking specific nerves via myotome assessment is much more complicated than dermatome testing, since the motor element of most individual muscles is innervated by nerves coming from several spinal nerve roots, rather than a single one seen with dermatomes. Take the latissimus dorsi muscle, for instance. The motor element is innervated by C6, C7, and C8. The reason for this is that the human body has evolved so that there's a backup system of other spinal nerves to still produce movement even if one spinal nerve becomes impaired, which, as you can imagine, was critical for the survival of our ancestors. Like if someone damaged their C6 nerve, they'd still be able to use the lat muscle actively, albeit to a lesser extent, through the C7 and C8 nerves. Also, having specific muscles supplied by multiple spinal nerves allows us to produce more precise movements and strength. For this reason, we check muscle groups rather than singular muscles when it comes to myotomes. Here's a list of the movements with the strongest association with each myotome. Have you anything to add regarding dermatomes and myotomes? We'd love to hear from you in the comment section down below. Additionally, if you're new here, make sure to like and subscribe to our channel. So that has been our video. Thanks for watching, and I'll see you next time.